I'm curious to hear what you all think, but I feel like with time, my adjustments for age and frailty have more been in dose and intensity rather than withholding medications.
Yes.
And so I still feel like triplet and even quadruplet
RVD
therapy is
light.
appropriate in the very elderly population, but maybe with attenuated dose and frequency.
So if you talk about practical kind of management here, so if you use Revlimid, would you start at a lower dose for a patient that's older? What's age cutoff about, and what dose would you use?
So for someone who's 81, I think I would, and especially with renal insufficiency and a low clearance, I would even maybe start at 10 milligrams. However, I've also given full dose Revlimid to patients in their 70s who are very well, and it is very idiosyncratic who can tolerate it and who can't. And even some younger patients can't tolerate full dose, and so I try to give patients the benefit of full dose as long as their performance status is good, even if they're on the older side.
In this patient, would you give Revlimid or would you do something else?
I think this patient I would give Revlimid. Yeah, I think I would probably give Cytoxan-based first therapy, but I would anticipate with this patient that with correction of calcium, and there's probably elevated light chains as well, that within a cycle the renal function would be more in a range where I'd feel comfortable giving Revlimid. But I do think the long-term data with IMiD-PI combinations is strong enough that you should probably try to get an IMiD-PI combination, and once the renal function is stabilized with cycle 2 or so, even if it's with dose adjustment for renal function.
So CyBorD, and then when you see improvement for the kidney, then you could switch over to RVD.
Yeah.
And
even if you
Revlimid.
and even if you don't get full improvement in the kidney function, as long as you're satisfied that it's stable, try to introduce Revlimid at an adjusted dose.
And the Revlimid dose you would do then maybe would be 15 or 10 or another dose, assuming that the kidney would improve here.
Right, so with normal renal function in somebody in their 80s, I would say 15 is where I would start as the high, but recognizing you may even need to adjust beyond that.
And would you do the bortezomib once or twice a week, or how would you do that?
So that's, I think, one of the main changes I would make for elderly patients is once a week bortezomib from the start. Really concerned about the risk of peripheral neuropathy early on.
Would you do it differently, Ajay?
I definitely wouldn't use lenalidomide in this patient for cycle 1. I mean, she's anemic at 7.6 with an IgA of 7,200, so there's a good chance you'll need to do a transfusion in a hyperviscous patient. Her neutrophil count is 1,400, so it's doubtful you'll get through a whole cycle. Her creatinine is 2.2. She also probably is at increased thrombotic risk because she's confused and has these bone disease, so she may be hypercoagulable from that perspective. So I think and finally, getting lenalidomide in a timely fashion with somebody whose calcium is 14.8 and IgA of 7,200 is challenging. So I would definitely do a CyBorD backbone with adding DARA because, again, time is kidney. And this I normally completely agree that I would only do once weekly bortezomib, but this may be a setting just for cycle 1 because of and in fact, some of the newer DARA, the VMP backbone even done in Europe, they do one cycle of twice weekly and then go to weekly, right? Because I think this patient is in trouble if we don't get the disease burden quickly.
If this patient came to me, I would probably consider admitting the patient
definitely.
older,
I would admit this person.
and then I would do CyBorD in the hospital twice a week with Velcade. And if the kidney is cleared, I would do outpatient. I would probably choose Revlimid 15 as my plan, and then do once a week with Velcade.
I agree. Actually, I might even go higher on the Cy. I might do like a 500 IV times 3 days, like a modified high-dose Cytoxan, depending on what other volume situation, but maybe previously plasmapheresis. I mean, this person is very sick. Yes. And just be aggressive if possible, and it's very hard to do this into a hospital, depending on cardiac status. I might even give carfilzomib, like a Car-Sci Dex, because of the disease burden. But if the renal function normalized and it turns out the patient is doing great, this might even be a good person for the MAIA scheme for doing DRD. That's up there too as a possible regimen too.
I would just use caution with carfilzomib in this population though, right?
Yeah,
so for example, the Clarion study was a head-to-head KMP-VMP, and there was no difference in the elderly population. And I think the issue is it is a very potent drug, and I think it's very well tolerated, but older patients we know have a lot more cardiac comorbidities, and you would need to do very due diligence of making sure there's no cardiac issues in this patient. But I just think that just needs to be thought very carefully, especially in light of the number one, when you look at the risk factor, the risk of heart failure overall is less than 5% across all studies. But in older patients, it can be as high as 15 to 20%. So
yes, it definitely has to be considered.
So there are obviously very many different ways of doing these things. So we use, as I already brought up, a lot of carfilzomib in our clinic. I think in my clinic, if this 81-year-old lady with all these labs being so off, came to me, I probably would do Cyborg-D for the same reasons, because it's easy to give. And if it really didn't work, then I would probably think about other options. I may have revisited carfilzomib, but I probably would have done Cyborg-D too. But there's nothing wrong trying that, but these are
Right, you
just
have to do due
different
diligence.
in opinions here.
And I would just want to send the uniform message, because I see this as kind of a mistake made sometimes, that I think there's almost nobody who can't get twice weekly Velcade for the first cycle,
Yes,
to
yes,
get the
I
site to
agree.
reduce the disease. So I completely agree.
Times
No
kidney.
matter what supportive have to provide in the hospital, intensive first cycle of therapy for patients like this is appropriate.
So before we move on to the next patients, I want to bring up kind of a little bit of a different twist here to an older patient. Let's say this patient was 81, but had labs that were pretty okay. There were no renal failure, there were no hypocalcemia, the hemoglobin was just barely decreased, and the workup shows multiple myeloma. If the patient came to you and was in great shape, say it was an 81-year-old that looked like a 60-year-old, how would you treat that patient?
I mean, Jane Fonda.
Like Jane Fonda.
Betty?
What I would need to know more details is with the crab symptoms, what is abnormal?
So let's say that there is one lytic lesion in L2, and the hemoglobin is 11, the kidney function is fine, and all the other labs are virtually within the normal ranges. And you do bone marrow biopsy, shows 40% plasma cells.
I mean, obviously, if there's a lytic lesion, then I think you would treat. But I think the question is if there's somebody who's, with the decision of treating or not to treating, I think, again, going back to what happens over time is very important.
But this is a patient that needs therapy.
Absolutely.
That's
No, but I think so I couldn't tell at first you were alluding to, is this a borderline smoldering and so, okay, so if the patient needs treatment, I think, but it's relatively well patient, I might do DRD.
So you would not use your RVD with daratumumab. Now you're switching to DRD.
I think, it depends. The advantage is obviously with sub-Q Dara. I think DRD is so good, and if it's a standard risk patient. I think the difference between the triplet and quad in an 81-year-old, I'm not sure it goes back to that risk benefit.
Nina?
I think I'd probably do RVD light or DRD, either of those, and it would just depend on, like, they have diabetes and have neuropathy already, then, just do that sort of thinking about what you want to have as a sequelae of your treatment.
Yeah, I would take the same approach as Nina, either a DRD or a attenuated RVD. Yeah.
Well, I think standard of care probably would do RVD light. That being said, I told you about the trial that we have done with the KOD DARA. When we opened that study just a few weeks later, there came a patient in with a diagnosis of myeloma in very, very good shape, 80 years old, and said, I read about this study, I want to go on. I know I fit all the criteria. The patient went on the trial, went into MRD negativity, and now is doing really, really great.
Yeah.
But I think an important distinction in the discussion point with the RVD versus DRD is, we use RVD as based on the SWOG 77 study, which was without the intent to transplant. However, that is not a transplant ineligible population, right? So the median
Correct.
age of that was only 63. It was twice weekly bortezomib. There was a lot of GI and neuropathy issues with that. And I think although it led to a response rate, PFS, and OS benefit, you cannot assume that that regimen can be given to your typical 81-year-old patient sitting in front of you. So if you're going to, so if you're going to, again, going back to the evidence-based high-level evidence, right? What is the high-level evidence that RVD light? It's, again, a single-arm study from Dana-Farber, great results, but there's not really a randomized control arm, right? So, and the question is also, how long do you have to continue the bortezomib? It was given for over a year. So you're giving weekly bortez, 3 weeks on, I think it was 3 weeks on, or initially may have been a longer cycle, but that's a lot of weekly visits, right? So I think DRD can be given on label. There's no dose modification required. It was, Maya had a median age of 73, and you can deliver the drugs as intended. And after the first 6 cycles, your monthly DARA, right?
And maybe sub-Q.
Yeah.
Eventually.
Yeah.
Would you eventually, if the patient said, I don't want to take this tablet, it makes me fatigued, would you do DARA once a month as a new maintenance?
I think that's where we have to distinguish between clinical trials. Clinical trials are always
This is
treat
not
to
clinical
progression
trial.
with
This is in your
triplet. But I
clinic.
think that's what reality is,
But
and people don't
Cassiopeia is gonna-
tolerate all these drugs, right?
And Cassiopeia is going to look at this.
Right, and so we can eliminate the drugs that are the least important or the worst tolerated for that patient, right? So you're going to monitor monthly labs on these patients anyway. You come in, get your squirt of DARA, go home.
So
you're
do you
done.
think DARA is going to be a new alternative maintenance for these reasons?
I think it depends on the population, right? So for the transplant population, it's hard to beat the len maintenance data with the OS benefit as well. So I think that is a high benchmark to beat. And so the maintenance studies that are being done are not DARA versus len, it's DARA plus len, right? So I think once we see that data, so I think it's premature to discontinue. But in this population, you know, I think what we know is that when you look at real world versus clinical trial, the median duration of therapy in real world at best is probably 70% of study duration. And so
Yeah, I totally agree with you. Like, if we do RVD light on this patient, are we going to do actually a year of Velcade? Probably not. You know, I would probably give the 8 cycles and do like IFM style and move on to rev maintenance for an 81-year-old, you know, something like that. So you're totally right about that.